Hello. Welcome to the session on management of symptoms in children with leukodystrophies. Firstly, I am Alasdair Parker. I'm a children's neurologist and a great friend of Alex TLC. It's been a pleasure working with everyone. And I'm based in Cambridge. You've probably worked out the photograph here is one of the beautiful backs where the River Cam goes through central Cambridge. And I'm talking to you about 400 yards away from King's College Chapel, which you can see in the centre there. Unfortunately, I'm talking 2 nights before bonfire night. So there are quite a few fireworks going off in the background. And please bear with me if we hear a few explosions. So in way of introduction, just a few terms that we use. So symptoms are a posh way of saying what are the problems the child is having rather than the underlying diagnosis. So that means that, you know, they're not sleeping or they're vomiting. The underlying diagnosis is likely to be a white matter disorder for parents who are listening into this session, or therapists, or perhaps other professionals. And the leukodystrophies, as you know, are a large group of disorders where the main parts of the brain are affected as what is called the white matter. And I'm sure someone's probably already said in the meeting that leuk is the Greek for white. So I want to talk a little bit about how some of the children come in and then how we manage these problems optimally. So the first thing I'd like to do is to talk about a child who presents to a GP and is likely to have some neurological difficulties and possibly loss of skills. And the GP will pick this up and refer to a paediatrician. What we hope is the GP will see you quickly, refer quickly, and the paediatrician will pick up the red flag signs of a leukodystrophy and hopefully prompt onward for referral and then quick diagnosis. But I'm sure you will already have heard in this meeting that, of course, we know there can be a delay and this can be very long. And here's a family affected by leukodystrophies. And obviously, thank you very much, Mum, for giving me permission to show the pictures. But these are the 2 boys in the early part of their journey. But then we go on and have dramatic changes. And if you look at the MRI scan on the right, I think you can see these very bright white areas. Hopefully my mouse will appear here. And the signal change is highly abnormal there in the white matter and would be strongly suggestive of a leukodystrophy at this point affecting the back part of the brain. So the children then are going to be investigated, often with blood tests, MRI scans, and more specialist assessments, sometimes skin, for example, skin assessment. And genetic tests these days are going to identify many of the causes. And for many of the leukodystrophies, we need to do metabolic testing to check we've got the diagnosis right. But the metabolic testing will often tell us whether the clue that we get on the genetic testing is correct. So after that, there's a diagnosis, and which may well be very, very and frightening. Hopefully done in a sympathetic way, with a team around you. And shortly after that, we quite often find that a lot of people arrive in families' lives. So of course, you know your GP or team of GPs these days, and you will have been in contact with a paediatrician by the time your child is diagnosed with the leukodystrophy. But a lot of other specialists start arriving, and these would include all the different therapists, physio, occupational and speech therapists, or terrorists as we call them. A radiologist may help with a diagnosis, and then you may be wondering, well, do they need to rescan? Are they going to give further advice? And there's often help for the geneticists. People are wondering if they need to meet up with them repeatedly. I'm hoping you'll see a neurologist, but we can talk a little bit later in the presentation on whether we're the central people or whether it's important to have other members in the team. An endocrinologist may get involved, as an example, or different specialists like gastroenterologists, orthopedic surgeons, and many more. And ultimately, it can be very confusing for myself as a specialist in leukodystrophies, and doubly so for families who are just starting their journey. So I'm going to talk a little bit about the building blocks that we need around to provide good care. And the central people here clearly are mum, dad, and the main carers. So that's people in your house, the family members, friends, but particularly parents and carers who are the first line involved. I want to reiterate that the GP is an essential part of this journey, and very often is excluded from important parts of information because there are some things in terms of symptom control that they're invaluable with and are the only people who can help you fix. There should be a main coordinating paediatrician. I'm going to come back to this at steady stages. But for me, if you have a disability, and all children with active leukodystrophy will have a disability, the role is best done by a community paediatrician. Now, the numbers of community paediatricians across the country vary, I'm afraid. And in addition, a specialist in neurodisability with part of the community paediatric team is particularly useful, but they aren't available everywhere. But if they are, empowering somebody who can be your lead coordinating paediatrician is absolutely essential, because we talked a little bit about that large team around the child. So symptoms are problems, and the next thing I want to emphasize is the virtually no problem you get in a leukodystrophy specific to a leukodystrophy. So sleep disorders are seen in virtually all children in my experience. So you don't necessarily need to be an expert in leukodystrophies to advise on sleep problems. And most of the difficulties we see in leukodystrophies that we give parents day-to-day difficulties, problems walking, distress, epileptic seizures as an example, these are seen very routinely by local multidisciplinary services. So yes, they can be a challenge, but it's very likely the local secondary team will have treated children with exactly the same problem, albeit not the same underlying cause. So either a different leukodystrophy or even a child who's got a neurodisability without a leukodystrophy, but just has exactly the same type of epileptic seizures, or the same severity of constipation with the same assessments and solutions. In terms of sleep, everybody needs it. And you know yourself how you are without it. So it's really important to stop and think how destructive it is for a child's performance and happiness if they don't get enough sleep. And from this point of view, irritability in the daytime, anxiety, distress can all be secondary to a bad night's sleep. And on this front, the community paediatrician can be very useful because they can do a standard sleep assessment. That's not necessarily a 2-week stay in a hospital. That could be a simple questionnaire for you. And some strategies to support sleep, mainly for non-drug ones are important at the beginning. Activity in the daytime is very important, lots of sunlight, and then an appropriate wind down in the evening and avoiding thinking about feeding passages and whether the child's in pain. But of course, for some children, the community paediatricians will be used to giving medication. As an example, we use melatonin as a safe drug quite frequently for children with sleep disorders, but it's good at getting children to sleep, but doesn't tend to keep them asleep. So we need other strategies there. But a community paediatrician will be dealing with sleep problems in virtually every day of their career. Eating is important. And we all know what kids are like if they're hungry. And it's quite common to get very hungry in the early stages of a leukodystrophy, and in particularly lose weight, which will greatly impact on initially the child's quality of life. And as the child's quality of life deteriorates, so will the rest of the families. And this is because the swallowing muscles can be affected. And children may need to eat a diet that's easier to swallow. And if you think the diet you give to a toddler with slightly mushy foods and then moving them on to slightly more solid ones, we give them that because it's easier for them to swallow. So we give children food that they can swallow at their swallow function. And we know we're winning if they're eating happily and their weight is following the same centile line on a chart. Support for this can be invaluable from a dietitian, and speech therapist helps you weirdly not with the speech, but with the swallowing. Some of our children in the later parts of their journey may find that they, despite fantastic support from carers and wanting to eat orally, they can't get all the nutrition in. And I particularly noticed this in teenage years. So although they may seem to be eating a lot, it's sometimes worth challenging yourself to think, well, my child's 14 now, seems to be eating okay, but how much did his elder brother eat at 14? Crumbs, he used to eat half an ox every evening. And maybe your child isn't eating quite so much. So the local pediatrician will be able to advise on that, and that's very routine. And we normally don't need to give medication for swallowing, although we do sometimes give that for excessive dribbling when we're not able to swallow the secretions very well. Movement disorders are particularly troublesome in leukodystrophies. And I want you to tell you that they're very problematic, but there's lots of things we can do to help. So most leukodystrophies, children will develop something called spasticity, where you're very stiff and get much stiffer if you quickly move the limbs, and something called dystonia, when you're kind of stiff all the time. And this is another lad in the photograph, again, thanks to Mum for the permission to use it, who has a movement disorder, and you can see his flexed up hands. But you can also get a flavour there that he's getting excellent care, because you can see, despite the stiff limbs, he's in a really nice chair supporting him well. You can see the wings behind the head. And if you're very observant, behind the ear, you can see a little patch of a medication we use for excess dribbling called hyoscine. And dystonia is a good example of how parts of the brain other than the white matter can be affected. Because although we characteristically see the white matter affected on the MRI scan, normally with leukodystrophy, all parts of the brain are ultimately affected. And the dystonia is a sign of when it's being affected outside the white matter. So for stiff limbs or difficulty moving, physiotherapy is invaluable. But I have to signpost you to say that physiotherapists in the UK do not visit every day and do lengthy exercises every day. They advise on joint ranges, movement, exercises, positioning, and then that needs to be done by the carers. But don't worry, at the end of the talk, I'll talk a little bit about how you can get support if you can't do all this yourself, because you can't do everything yourself. But also the occupational therapist will look at seating as well and supplies particular equipment. And the equipment has a posh name called orthotics, is the general group, or orthoses. Now I'm going to get in terrible trouble from my colleagues at the Evelina, because I gave this lecture a few years back and kept saying how medication is no help. And Mum asked the Evelina team to reduce the medication. But by this I mean I will come back at the end to say that I'm going to give some very negative messages about medication, but it is useful at sometimes with realistic aims, and I'll come back at the end. But in isolation, medication treats spasticity poorly and dystonia poorly. If you don't do the other things with positioning, exercises, and some other things that can worsen stiffness would be boredom, pain. A good example of a painful child is one who's very constipated. So we do need to tick off quite a few boxes when we're treating children, but there are some journeys with stiffness on medication I'll come back to later on. I mentioned orthoses are a posh word for equipment, and there's plenty of help from better seating through to the lads we've seen with the excellent seating systems, through to very sophisticated things such as a motability vehicle in this picture, wheelchairs, maybe the child needs a stair lift, or maybe their leukodystrophy is so advanced you can't transfer them from a chair to a stair lift, in which case you may need a through floor lift or single floored accommodation. Because one of the things we need to plan for is something I was taught by a really lovely girl with multiple sclerosis many, many years ago in South London. And I spent a long time explaining to her about some of the difficulties which we needed to think about. And after my kind of 10-minute long lecture, she summarized it in a few words and said, Dr. Parker, I think what you're trying to say is we need to plan for the very best, but expect the very best, but plan in case it's not so good as that. And that's lovely. So we do need to expect children to have a good quality of life, but we need to plan in case things aren't as good, and we need to start supporting them in different areas. I find visual failure can be a challenge. And when you can't see very well, and this is the lad in the photograph who can't see very well, we can get a lot of distress and disability. Early referral through to visual impairment teams can be invaluable because they are normally very professional and adequately resourced and able to advise you on how your child can interact to visual stimuli, or how they can interact with the world if they really cannot see. And as an example, there's no reason why your child can't get out, even with severely visually impaired, for a walk, but may need some support doing that. And that team have teachers, doctors, and orthoptists with them. Confusion is a problem for anyone who's got difficulties with their cognition. And many of you listening will have had a relative, an elderly relative, who begins to get a little confused because they don't know what's going on. And the important point there is we use just the same strategies. We identify why they could be confused, and we treat it as we would for anyone. So we make sure the world is easy to understand and navigate, and it's akin to a child who has suffered a traumatic brain injury. Sometimes we need respite, carers and teachers or school to learn that the child is not able to understand as well as they could previously, and things need to be explained to them very, very carefully and slowly. Sometimes the pictorial cues can be good if they have vision, or auditory clues to help them. No surprise there again. So sedative medication in particular for confusion is particularly bad news because it confuses them more. And we've learned in adult care not to give sedative medication to adults with confusion. Some of the psychiatrists give drugs to people who are very confused and agitated to reduce anxiety or reduce depression. That's another issue. But it's not going to fix your confusion or understanding of the world if you sedate them. And that leads me on nicely to distress. And that can be a very major issue and have a very negative impact on quality of life for both the child and the carers. So from that point of view, I would like you to expect periods of distress. I'd reassure you we get periods of distress in all young people, don't we? But it is more problematic in leukodystrophies. And there are structures and things we can do to really help. So we often get a kind of overall area of irritability. And again, people may want to try some or offer you medication. But what you actually need is what I would call critical and complex action with distress. So from this point of view, the young person may not be able to tell us what they're distressed about. And in fact, that's like a lot of young people, isn't it? Your angry teenager doesn't necessarily tell you why they're so angry, but they're certainly angry. And your toddler having a tantrum will also be expressing emotion and distress, but you won't necessarily know why. And what we normally have to do there really is to work through a checklist of things that could be upsetting them. So some of the low-lying fruit include hunger and difficulty swallowing. So just check with the dietitian they're eating enough and their growth's okay. And if they're having difficulty swallow, a speech therapist can be valuable. And sometimes later in the journey, support with specialist tube feeding. Pain obviously is a cause of distress. And if you haven't treated for children with a complex disability, you may not be aware of what can give them pain, such as tight hips can give you pain. I mentioned constipation, but sitting too long in the same place, if you think about your bum as you're listening to this lecture, if you've been talking for a long time, it'll start to get a bit sore, won't it? So we need to stretch children and move them around. Boredom is an important one, and school's invaluable for helping for that because it's a dynamic and busy environment. So it's absolutely essential that children with leukodystrophies get the option of going to school on a daily basis. There are some parents who find in the latter part of the child's journey that it distresses the child, and obviously that's a different question. But for most of the children, it's great to get boredom alleviated. And these days, I found that we as parents are older, grandparents are quite a lot older and aren't always able to give all the physical care that they did when I was a younger doctor. But now, as the grandparents are a bit older, they can be really useful in interacting with a young person and alleviating boredom. And mobility is really important for that, because if the child can't get into a chair, they can't get into a wheelchair, and they can't get out of the house. So essential to keep working on that. And when the child is distressed, I think it's really important to share that between the school, the family, and other people, such as the Respite service, and multidisciplinary team discussion around that area. You will get specific conditions, and I'm just going to mention a couple, no more than that. Epilepsy is a relatively frequent fire, but again should be primarily managed by a secondary specialist, because the drugs we use for leukodystrophies are not specific to the leukodystrophy. They're specific to the seizure type, and it's likely these children with leukodystrophies will have typical epileptic seizures we see. Joint problems and stiffness may require support from the orthopedic team. Social care are essential in the journey, and I think previously people were resistant to getting social workers involved because we had a perception that they deal with safeguarding issues around children's care, and actually that's probably a very small minority of the small proportion of the work that social care do. What they mainly do is support families caring for both adults and children with disabilities. And I've heard it expressed repeatedly that it's difficult to get engagement from social care. And I think that's a matter of communication, because my own experience of getting the social care involved with my elderly relatives has been very easy, and it's been very good. So I think we possibly are going in the wrong direction with getting them involved. And it may be we're giving them information about the leukodystrophy that's too complicated and disempowering. So early engagement is really good at a time when the child has got a disability that's not too complex. But as an example, you could ask them some things which they really do know how to do, like disability, mobility allowances. And one of the key areas is, if we talked a little bit earlier about the boredom and all these different issues that the carers are going to have to do, and it maybe you need a bit of extra manpower. And certainly we can get care assistants to come and support you. I have known it work with both ways. Sometimes the care assistants are delegated for the child, but when they come to the house, the care is so complicated with the child, they've done a bit of work with the other siblings while mum bathes the child or gets them ready for bed. Respite care, again, is an important service that social care can offer, and quite often comes from the hospice services. The great majority of the care they give is not around the time of when children are dying, but around earlier points in the journey. We need a lot more support. But in terms of respite and somebody else to look after the child so that the carers can get on and clean the house, do the shopping, school is the really important one. Because the number, being able to do 9 to 3:30 every day of term time for 40 weeks a year is dramatically more time in terms of respite than social care will provide with a respite carer. So I've mapped out quite a lot of specialists who may be involved, and we've kind of put together what we call a multidisciplinary team, and that will be needed for all children with leukodystrophy. But it's important, what I think, when we first make the diagnosis, that we empower all the different members, most of whom will not have heard of either a leukodystrophy or a specific leukodystrophy, such as Tay-Sachs or adrenal leukodystrophy. So we empower them with knowledge that the symptoms we're treating are not particularly complex, and they're things they're dealing with all the time. We're getting the speech, physio, and occupational therapists, amongst others. I mentioned the dietitians, didn't I? And secondary lead, caring for children with complex disabilities, is absolutely essential, not tertiary neurologists or metabolists or geneticists or radiologists, because they know what's in the locality and they have access to the specialist services the family will need. Whereas the third level specialists in places like my centre in Cambridge or Great Ormond Street or the Evelina Hospital or Manchester Children's Hospital, They won't be able to deliver the care these children need because they won't have access to people on the ground. Clearly, they'll add into a multidisciplinary team, but the other key players I've come back to repeatedly: educational social care. So, briefly summarising the building blocks of the team, the first is the family and carers around the child. We're putting together a local multidisciplinary team. We're getting specialists in when there's a key question to ask them. I'm very uneasy with "we'll see you in a year's time," because actually it's likely the family are going to have lots of contacts, and it's really important that you only have the contacts you need to have. And these are the ones when you have a question to ask the specialist, or there's a key assessment or treatment decision that needs to be made. So I don't always repeatedly see children with leukodystrophies. Actually, what I normally do is help with the diagnosis, offer to see parents relatively soon after, and then say I'm very happy to see them on a yearly basis if there's a question they need to ask me. And I would say about half the families come every other year or every other year. But then occasionally they do need to come to see us when there's, inverted commas, an emergency. Now, most of the strategies I put in are trying to avoid these emergencies, but we can't always do it. So if a child's a bit stiff and then becomes dramatically stiffer and can't sit or sleep or feed, that's the point when I would like to be contacted, or my on-call team would, in case I'm away. We've talked about the neurologist there a little bit with stiffness, but also seizures, distress. And it's difficult to plan support if you don't know where you're going on the journey with leukodystrophy. So although we never know what the future may hold, I think the neurologist can educate about what the average child does with that genetic or metabolic change. And then we may use other specialists, particularly I was thinking gastroenterologists for feeding and nutrition, as well as the orthopedic team. Now, here we go. Medication, I've said you can't use it, but you can, of course. It's really helpful and has a number of different areas. And I'm just going to give you a few examples here. So for drooling, I tend not to use the patches anymore, but there's something called glycopyrrolate. So if a child's drooling excessively, we can cut down the amount of drool they produce, but it can make them too dry, which makes you constipated and give you difficulty passing wee. So these medications need to be given carefully with some surveillance. I talked about medication for stiffness, not being helpful in isolation, but we certainly use baclofen for spasticity and some other medications for dystonia, and occasionally escalating to things like Botox injections, which relax the muscles. I said melatonin can be really useful. And for seizures, we may need to give carbamazepine or another anti-epileptic drug. Just getting a phone call there, which I'm just going to ignore. But what's really important here is that we don't have inflation of medication, because we can find a child ends up with 3, 4, 5, 6, 7, 8, 9 drugs. And from that point of view, reducing the keeping the drug numbers as low as possible is good. And when you have more than about 3 drugs, we normally have a plan for when you've got one in, put a new one in, take one out. So in summary, build a team, but there's no hurry to do this. Build it slowly, work out who's doing what. Family and local services are central to that, with a local paediatrician who should be able to identify, assemble, and empower the team and support the families. Use key professionals judiciously. Medication can be useful, but rarely in isolation. I thank you very much for listening.